My name is Suzanne Paulson. I'm the CEO and the founder of iEco. And I'm really happy that you're joining us today because we've got some extraordinary information that we're going to share on how you can step it up in the management of your moderate to severe MGD patients. With me today is an absolutely incredible panel of dry eye experts, the brightest minds in the industry. And I'm sure they're familiar names to all of you, but they deserve introduction. Dr. Laura Periman, ophthalmologist out of Seattle, Washington, who is just everybody knows Dr. Periman. She's so passionate about dry eye, decades of experience. We also have Dr. Leslie Odell, who is the medical director of Medical Optometry America out of New Freedom, Pennsylvania. And of course, Dr. Odell has a long-standing history of dedication to dry eye patients, as well as Dr. Crystal Brimer, just the same. She's the founder of the Dry Eye Institute out of Wilmington, North Carolina, and has the equal amount of passion for treating dry eye patients. We also will have shortly Dr. Amy Now, who is of course the partner of Corbin Associates, and we just can't wait for you to hear what we have to say. It's going to be divided into two sections. We're going to have Drs. Odell and Brimer go through some really exciting new clinical research on pearls that you want to be able to really take away in the management of your MGD patients moderate and severe at home, as well as the second half is going to be Drs. Periman and Now with some real insight to some of the really big missings that you do when things to look for when you're looking at your moderate to severe MGD patients that can make an amazing difference in the quality of their life. So without further ado, I'm going to kick it off with Drs. Odell and Dr. Brimer. Dr. Odell, you want to start?
Sure. Well, thanks so much. It's exciting always to be able to present alongside these wonderful doctors. So we appreciate you, Suzanne, for bringing us together and helping us raise awareness around the importance of at-home care for our patients. This really has evolved, from my time first thinking and speaking around meibomian gland dysfunction. I can remember actually encouraging some of these behaviors that you see on the left-hand side of this slide. I would tell patients in order to heat their eyes properly that they should boil an egg and put it on their eye, which now I think about as, this completely absurd thing. But at the time I thought, like many people, it's the shape of your eye. And what we didn't know was who knows how hot that egg was getting, and what kind of temperature we were seeing. The same is true with the boiled potato, rice in a sock. These were all things that we had to do before masks that are microwavable or gel-based became available for our patients. So we were trying our best with the materials we had.
Well, and Leslie, I think there's doctors out there who still recommend that. And so this is going to be good information for all of us. I think sometimes the doctor themselves wants to see the differentiation between the mask and understand it. But even when we do understand it, some of us are struggling with how to make that case for the patient so that they are not using something they bought off of Amazon or found at Marshall's last week. I've had some really crazy things be brought into the office before. But so that's one of our goals today, is to kind of give you the ammunition to have this discussion and to be able to differentiate between the mask with your patients.
And I think it really comes down to understanding where temperature lies and why temperature is so important. Even if you think about that slide that we just showed and the warm compress with the washcloth, that's the one I probably hear most often from doctors. If I'm seeing a patient, new to me for dry eye, they might be doing just a warm washcloth. But science has, really disproven that is very effective for our patients, because not only does the temperature matter, but we'll show you that the duration of heat matters as well. With temperature, you really want to be achieving this 102 to 110 degrees Fahrenheit. And that's because if you think about what you're doing to warm the lid, you want to be warming the meibomian glands, which are not superficial completely to the eyelid skin of a closed eye. You have to heat through skin, muscle, blood vessels, and some fat actually to achieve that inner lid temperature that we want to see the meibum start to thin. So temperature matters. And so finding a mask that heats safely to this, 102 to 110 range is important.
And duration matters. The problem with a lot of the microwave masks is that they do cool off within that 4 to 5 minute range. And that might be okay for your mild MGD patient, but it's not enough for your moderate to severe MGD patient. They need 15 minutes or more. And it's just like what Leslie said, that heat has to go through quite a long distance, a lot longer than it seems, to get to the meibomian glands to do the job.
So, I do think about that magic in the duration, and I do tell patients that when I'm doing an entry-level mask that I want them heating for the 6 to 10 minutes. But as soon as I start to see more moderate changes to the glands, whether it's structural or function, I'm really looking for an extended duration mask, because I know that it takes longer. The melting point of the meibum is actually higher for patients who have more advanced meibomian gland dysfunction. So we need a longer duration heat for a longer amount of time. And the moist heat really makes an impact on how you're able to conduct heat through these layers that we were talking about to achieve that temperature at the meibomian gland. If you think about just the difference between moist and dry heat, if you're going to put your hand into a boiling pot, it's going to burn, significantly, versus if you just put your hand into the hot oven. So, there's the difference between just the way the moist and the dry heat works. And there's a lot of science that backs this up. With moist heat, you see a faster transfer through the eyelids to the meibomian glands. The increase in humidity also helps to stabilize the tear film. It also increases circulation, so that's thought to promote healing for patients. And that increased blood flow also helps to keep the eyelid skin and surrounding tissue healthy.
Yeah, and the dry heat's going to do the opposite of that. It's going to pull moisture away from the eyelid, that sensitive skin, and decrease the stability of the tear film. This is going to contribute to dry skin in that periocular orbital area. And then we risk burning the eyelid. And this is my biggest concern when patients are bringing in these plug-in masks and these battery-operated masks, is that dry heat and how hot it does get. And I do that. I tell them, I say, bring them in, let's look at it, because some of them are going to be adamant about what it is they're using. And then I kind of pick it apart and tell them all the reasons why it's not going to be as effective for our goal and that it can be dangerous.
And so when you look, now we kind of are inundated by these entry-level masks that we've been talking about, the ones that are microwavable. Some of them are, I think, just kind of air activated. Some of them are the dry heat that are plugging in. I don't know what your conversation, Crystal, is with patients, but again, if I have a mild dry eye MGD patient, I am okay using one of these entry-level beaded masks. And that's usually, to me, a patient that when I'm grading the meibum, I'm actually getting a release, from my, I do meibomian gland evaluation using the Corb evaluator. And if I can actually get oil to release from the glands, but it's just not all of the glands, then I feel comfortable with an entry-level mask. But quite frankly, most of my patients are more in that moderate to advanced, where I know I need this 15 to 20 minute heat mask. And these are only around 6 to 10 minutes.
Yeah, same thing with me. I don't have a lot of patients who are not getting the recommendation for the longer duration mask, because I don't see a lot of routine patients. But I can imagine, like, if you've got contact lens practice, that one of the microwave masks would be an okay option for them. But for your dry eye patient, I just don't think it's going to be enough. And because of this research that we've talked about, and because of the findings that we're about to show.
I think that some of the ones that do make me a little fearful are the plug-in ones. I think that some of them, can heat quite hot. I think 130 degrees Fahrenheit, which would be, not ideal. And the other thing that has been interesting over the years is to see just the inconsistency of some of those masks, that they can achieve levels that could cause thermal injury to the eye just from microwaving it a few seconds longer in the same microwave. So, you really got to consider those things for patients as well. And although there is moisture being released from a lot of, the beaded masks that will release, it's just not the same as some of the longer duration masks.
Exactly. So to summarize, what we've got is No, Suzanne, go forward for us on that one. So to summarize, we need 15 to 20 minutes of extended heat. We need sustained temperature between 102, 110 degrees, and we need a humidity of at least 80%. But just as important, we need it to be repeatable. And that's like what you were saying with the microwave ones. You've got the same mass, the same microwave, but if you ask that patient to reheat it after the first 5 minutes, now all of a sudden everything's gone out the window as far as consistency, and we need it to be safe.
That is a great point. I actually just had a patient that I saw recently that was using a beaded mask, and she was doing it twice a day, but sort of twice a day back to back, and had no idea that it doesn't heat, as well until it's kind of, several hours after they heat it the first time. So even just educating patients to how they're using these masks so they get the most repeatable type of temperature is important. And safety, of course, is something that we worry about. Well, so what I set out to do, and I was so excited to have Crystal on board with this, I really wanted to look at what would happen if I did a meibomian gland expression in the office using a mask that not only was heating, but actually was vibrating around the orbital bone. So it was going to provide me 20 minutes of heat in the optimal range using this moist humidity type of mask. And I used the Tranquil Vibes mask to do that. And then sent the patient home after meibomian gland expression at the slit lamp with something we weren't sure about, either a Tranquilize XL mask or a Tranquil Vibes mask. And the reason that these two masks were chosen for at-home care was because of some of the things we just were talking about. One, they both achieved this ideal temperature of 102 to 110 degrees Fahrenheit. They both achieved the duration, 15 minutes to 20 minutes of heat. They both have the humidity that we were looking for with 80% humidity or higher, the consistency and the safety. And so really it was to challenge, how we could optimize an in-office procedure to improve signs and symptoms for our meibomian gland patients.
So as Leslie said, we had 4 sites, and I was honored to be one of those. We had 35 patients in total. And during that first visit, we did extensive baseline measurements. We had every single patient, no matter which they eventually got selected to take home, which mask they went home with, all of them used the Tranquil Vibes, the vibrating one, in the office for 20 minutes. After we took the mask off, we immediately did gland expression, and then they were randomized as to taking home the Tranquil Vibes or taking home the Tranquilize XL. And then they committed to use those masks every single day for 30 days and make little notes, and we brought them back in, repeated our measurements, but also we repeated all of the surveys and dry eye questionnaires that we'd given them in the beginning.
So it was a fun study for patients to be involved with too, because they had, a lot of the patients, hadn't maybe used extended duration masks. So just to really introduce them to the difference between a beaded mask to something like this. And I will say that when the patients returned, the vibration really added a whole other element of comfort and relaxation. And it was exciting to really get to the results, because it was kind of the first time that I had actually dealt with any kind of vibration and heat simultaneously. So we looked at, like I said, we looked at both signs and symptoms. And for symptoms, we used both the SPEED questionnaire as well as the DEQ-5. And we were really excited to see a significant improvement for both of groups. So in the Tranquil Eyes group, which was just the heat without vibration, we saw a 35% decrease in symptoms. And for our, I'm sorry, that's the Tranquil Vibes. And for the Tranquil Eyes group, we saw about a 29% decrease in symptoms. So that's, a third decrease in symptoms in just a month after treatment, which was really encouraging.
Well, and similarly with the DEQ-5, 37% and 28%. And the thing that you'll continually see throughout all of these results is that we had incredible results even with the Tranquilize XL, so the non-vibrating mask. And that was the only difference between the two, was the vibrating. And like Leslie said, patients really enjoyed it. I know that as far as just their enthusiasm to do the mask day after day. But similar results in both because they met that criteria that we talked about earlier with the duration, the temperature, and the moisture.
I was delighted because I'm always excited to improve visual quality for patients as much as I can, and that's a big part of when we're treating meibomian gland dysfunction. So to see these increases in stability of tears was really exciting. So we had big gains in tear breakup time for these patients in the Vibes and the XL group, 69 and 72% increase. And if you look at the numbers, if I have a 4 or a 3.5, that patient on a tear breakup time is really going to have their lifestyle altered. If you're breaking up, within 5 seconds of a blink, by mid-afternoon or early evening, you're certainly going to start noticing that blur or burn or just discomfort with your eyes. Makes you want to maybe pause from your computer use or just kind of close your eyes to take a break. Once I start getting this 7 seconds at 6 and 7 seconds, as the closer I'm getting to 10, that is going to optimize vision for patients, increase the tear stability, and make the patients more comfortable longer into the day. So these were big wins in my mind for this study.
And same thing with lysamine green staining, another big win. Now, I think a lot of times lysamine green staining or conjunctival staining, let's say, goes under the radar because we're not putting the lysamine green in. And if you listen to Dr. Karpecki earlier, he said, you can pick that up with fluorescein and a retin filter. So that's another option. But in this case, both the Tranquilize and the Tranquil Vibes decrease conjunctival staining.
And corneal staining, which is also, exciting to see. So this one, I think that we're a little bit, more adept to seeing and in tune with, but I agree that conjunctiva and the lysamine staining is really an early detector of change. Sometimes you might pick up lysamine on their conjunctiva before you even see the corneal staining, but in order, because the stability of the tear film was improved, I would assume that helped to decrease the staining that we saw for these patients. And again, pretty significant for both groups.
So, like we said all along, incredible results for both categories. And yes, in the majority of them, we had a bigger decrease in symptoms and signs with the Tranquil Vibes versus the Tranquilize XL, but incredible results in both. And it's because it meets those requirements that we talked about, but reduction in speed symptoms, DEQ5 symptoms, increase in T-butt, decrease in both conjunctival and corneal staining.
And now I think the way that I'm using this in my clinic now is to perform in-office procedures using a mask, and then I actually can send the patient home with the mask I use to do the treatment. It makes meibomian gland expression a lot easier than any kind of cold expression. Obviously warming the glands and achieving that thinner meibum helps you push out that secretion, which is going to improve symptoms for your patients and also the stability of the tear. So I think it's a great way to kind of adapt the study for your own clinic, is to use these masks as your in-office way of doing meibomian gland expression and then sending the patient home to continue care.
Yeah, what we do is we use the Tranquil Vibes in the office. So it's not the one that they necessarily chose to take home. A lot of them are taking home the Tranquilize XL, but I made my little relaxation room and told patients anytime they want, they can come by, have a seat, we close the curtains and just sit, relax with their Tranquil Vibes. And it doesn't increase chair time because this has nothing to do with their appointment time. They're going to come in before that, and then we're going to pull them back and do the expression just like I would have done anyway.
I like this relaxation room. That's a great idea.
There's some COVID modifications, but it's been nice.
Yeah.
Super. Okay, well, thank you so much. I'm really excited, obviously, about this information, and I think that another really important part of it is that it's if you're doing just manual gland expression, even just there's something you can be doing for these moderate to severe MGD patients now is clinically proven. to help improve signs and symptoms. So we're going to continue on to the second half of this, and we're going to thank you very much, Drs. Odell and Brimer, for everything you did in this study. And we're going to be bringing back Dr. Periman, hopefully Dr. Now, if she was able to join us. And then we're going to continue on a discussion of something that I think you're going to find very, very interesting, which is all about nocturnal evaporative stress. So Dr. Periman, how are you?
I loved your data. Strong work on that study. And yeah, it's I employed these techniques in practice, and I just really appreciate your awesome data that you generated for us. That's good job.
Okay, so nighttime.
Really appreciate it. Thank you, Dr. Periman.
Nice. Yeah, so nighttime considerations. Have you ever had that dry patient that's not getting better with your perfectly laid out plan, and you start asking them more questions, and then they'll admit to you, well, I've always woken up early, like first light wakes me up, or my eyes feel terrible first thing in the morning. I have to put drops in to get them going. Think about nighttime evaporative stress. These are gross examples, meaning, frank examples of nocturnal leg ophthalmos, and that has a consequence for the poor cornea and the ocular tissues. That nightly, hopefully 8 hours of sleep where you have incomplete lid closure, exposure of the ocular tissues, that is ongoing desiccating stress, night after night after night. And everybody knows that desiccating stress is an independent driver of chronic inflammation with dry eye disease. So without the adequate protection of our eyelids, without the mechanical protection of these windshield wipers Mother Nature blessed us with, we have inadequate protection of the eyes at night. And some severe cases may be surgical, gold weights, mid-face lifts, fillers, tear trough fillers, mid-face fillers, you name it. But what about those subtle cases? What about those pre-surgical cases? What about those subtle cases? And my index, when I first read some of the papers that we're going to share with you in a minute, I thought that is one that actually, I take it back. It's the most easily to integrate clinical pearl that I've ever received. And so it's my favorite one to pass along to others, is the how to look for lid seal insufficiency. So how do we diagnose this? Make sure we're all accustomed to being at the slit lamp and getting our stains out and then looking at the eye up close like this under the slit lamp, right? But don't forget to look at this whole area. Don't forget to look at the entire person. You'll start to see little clues. So let's go on to the next slide, please. Okay, so this paper was a wonderful addition to my clinical fund of knowledge. And this is a paper by Korb and Blackie, and they described compromised lid seal in patients with refractory dry eye disease and asymptomatics. And when you learn to identify this lid seal insufficiency, I think it will, and knowing that there's such easy thing we can do about it, I think you'll be more successful in your dry eye practice. So in this particular paper, there were two different populations. Very symptomatic patients that have failed everything and patients that weren't symptomatic yet, right? It's coming. We all know it's coming. So we want to catch that before that point. They did the Korb-Blackie light test, and I'll explain that in a second. And it was a scale from 0 to 3. 0 is a nice complete lid closure, and 3 is there's definite light escaping under the door there. And how they did it, and this is how I would encourage you to do it, is take your humble muscle light that's just sitting there waiting the vast majority of the time in your stand by your slit lamp. Take your little muscle light. All I have is a pen light today. Ask the patient to close their eyes and relax their face, right? Your older patients are still overacting their brow because of ptosis, right? Ask them to relax their whole face. Take that light in a darkened room and shine it right at the superior sulcus, superior tarsus pointing down at the interpalpebral fissure. I don't know if you can see it, but I have an inefficient lid seal. And I wear a mask every single night. Helps me tremendously. In this paper, 80% had a compromised lid seal, a 1 or 2 or a 3. And the asymptomatic group, very few of them had this lid seal insufficiency. And I think if you go on to the next slide, I hope Oh, there's a corollary to that. Yeah, that's okay. You can keep going. I wanted to say there was a follow-up paper where they then went on to describe a this lid seal insufficiency as being a risk factor for meibomian gland dropout. And so be on the observational lookout for cases of significantly asymmetric meibomian gland dropout on your meibomography. We use infrared meibomography on every single patient. But when you see a marked asymmetry, make sure you didn't overlook your light seal insufficiency test. It's amazing how many times that really does correlate with it. You can catch it in young people too. I've caught it in college kids, younger kids. So it's make sure you think about it. But one of the things I want to talk about when it comes to lid seal insufficiency is not only how, you know, Mother Nature puts your face together, but there's, you know, downward tractional forces with gravity and aging birthdays. There's breathing apparatus issues that happen at night. When you're asleep, your brainstem loses the tone in your oropharynx, and that oropharynx can then collapse back into the back of your throat, creating a temporary obstruction. Well, the oxygen levels then start to go down, and that's called hypoxia. And the hypoxia wakes up your primitive part of your brain that's responsible for respiratory drive. Whoa, oh, I need to breathe. And so the consequence of that is you never get into deep stage 4 sleep. It used to be that you had to go to a sleep center for that. Thankfully, there are kits that patients check out and take home. There are Fitbits and Apple Watch type fitness type devices where you can ask your patients to screen themselves for snoring and inadequate deep sleep. The solution to it is still CPAP, right? So CPAP helps to maintain a bit of positive pressure so that if there's that temporary obstruction in the back of the oropharynx, you can still push some air past it and eliminate those hypoxic episodes, which prevents those wakeful periods just enough to start breathing again. And then you go back to a deeper sleep, you block, and the cycle repeats itself. There's a consequence to all that hypoxia. Go on to the next slide. And go one more. There's a consequence to this, and it's called floppy eyelid syndrome, which, you know, we probably need to come up with a more flattering term, but we're stuck with floppy eyelid syndrome as it is for now. And sometimes I'll miss it until I go to do the dilated exam, and then you've got your indirect there, and you pull the lid back, and you're like, hold up, why can I pull that lid so far? Let me look a little closer. Oh yeah, there's a little bit of temporal lashtosis. Look again at the slit lamp. Oh, I see a little bit of a papillary conjunctivitis change. There's some lacrimal gland herniation there. Those are all physical exam findings consistent with floppy eyelid syndrome. Be on the lookout for it. It's not just an old, overweight, former linebacker's disease. I've seen teeny tiny women with this as well. So you can't make gender or weight-based assumptions about obstructive sleep apnea. If you identify floppy eyelid syndrome in your dry eye patient, understand that the windshield wipers responsible for protecting the eye, responsible for blinking, spreading the tears across the eye, is abnormal. There's a mechanical aspect to this dry eye. You know me, I'm always talking about the immunologic aspects of dry eye, but this is a mechanical driver to the problem, and we have to learn to recognize it. The correlation between floppy eyelid syndrome and obstructive sleep apnea is in the 90+ percentile. In the reverse, only about a quarter of OSA, obstructive sleep apnea patients, have floppy eyelid syndrome. So what we think is happening is the chronic hypoxic episodes create an ischemic injury around the muscle of rheolon, which surrounds the meibomian glands and is responsible for that tiny bit of squeeze of meibum with blinking and forceful closure. Those are abnormal and weakened from chronic hypoxic injury, and also the hypoxic injury is associated with very high levels of MMP9, and that's responsible for the breakdown of the elastin in your tissues, and that's where you get the floppy, lax lids instead of the nice, normal tone and texture ones that we need in order to protect our eye when we're sleeping. Next slide. So there's lots and lots of causes of it. It could be the way we're born, right? If you have a lot of tonsil disease and you're a kid, maybe you sleep with your mouth open, the face is longer, this is a little short, so that lower lid doesn't come up as high as it needs to. I've seen blepharoplasties, beautiful cosmetic result, short sheeted the bed, and now we've got an exposure issue. We can soften that scar and improve things with IPL, but we also need to protect those eyes with a silicone vaulted ceiling night mask. Thyroid eye disease, as the proptosis gets worse, as the lid stiffens from all of that extracellular matrix proliferation, then we can't, there's somebody knocking at the door. I can't answer the phone, I'm so sorry. And this is live, isn't it? Sorry, guys. Okay. High myopia, the eyeballs coming forward, trauma to the eyelid, of course, over aggressive Botox. Be careful with your Botox, right? So you want to make sure that your Botox patients are not receiving Botox here. This weakens the orbicularis, weakens the ability for lid seal, also gets uptaken by the lacrimal gland and directly decreases lacrimal gland output. No Botox here. And then finally, we've got just the effect of gravity over time. Next slide. We've got lots of options. Back in the day, I used to use these neoprene vaulted ones, but they get a little swampy. They get a little nasty over time because the bacteria, they're hard to clean. So I went away from those as soon as I found these silicone vaulted ones. You still need to wash it every single day, but it's so much easier to get it clean than these fabric-based ones. And the vaulted design is great because the fabric ones, I've seen cases of corneal abrasion at night from wearing the fabric flat masks and that eye opening just a little bit and creating an abrasion. We want to avoid that. And let's see, and a lot of people do that. Anyway, humidity is created to the ocular surface. We all know that. We want to keep the moisture there, slow down the evaporative load, maximize the function of those precious meibomian glands. It's all part of the game in addressing dry disease. It's such a big diagnosis. And really, if you start listening for these little clues and just incorporating a 10-second additional thing in your physical exam, you're going to identify some of the nightly stressors that are getting in the way between your patient's relief and success and your satisfaction with dry eye disease. Easy thing to do. Patients are so relieved when I say, oh, this is a $60 fix. Don't recommend swim goggles unless, you know, your marriage isn't doing great. The saran wrap method. The saran wrap method. I don't recommend that either. I've had patients come in with their skin completely, like they've been sitting in a hot tub all night long. You know how the skin gets really friable and overhydrated? That's what happens when you have a totally occlusive dressing. So the saran wrap's not a great thing. Ointments can dry out and create irritation. I'm not a fan of ointment. Highly recommend you avoid Muro for this application. That adds to the desiccating hyperosmolar stress. No Muro. Next slide. I love these masks, so I keep them in the clinic and have the patient try them on. They're compatible with CPAP use. If you don't have sleep apnea, you just have a simple inefficient lid seal, it's brilliant for recreating that protective environment for that precious cornea and ocular surface tissues. And it's affordable. You can side sleep, you can stomach sleep, and it's not going to raccoon you. It's not going to push and pressure and give you a corneal abrasion. And patients adapt to it very, very well. Next slide. Oh, and clear and dark. So I live way up in the north, in the Pacific Northwest, right? So the dark ones are for summer solstice time when it gets light at 4:30, and the clear ones are at winter solstice time when it gets dark at 4:30. Next slide.
Well, that's it. Just some final thoughts. We're going to bring the in time. Thank you so much, Dr. Periman, for all of that. I think that it's one of those things where I have lag ophthalmos myself, and there's no way I can sleep without the ISO 4.0 every night. But
and I think that, you know, I do like the clear, and there's also a lovely line of colors that I have fun with, like the hot pink and the green and the lavender. Like, it's very fun to think about, you know, and the patients appreciate, even though they'll say, who's going to see this? You know, I can't see it, but it's kind of nice to have something that's a little fun color.
I love it.
Suzanne, we should find a line of printed silk pajamas that pick up all the different colors that you can like be coordinated.
Yeah, we used to say that a long time ago. To just pick with just the original Tranquilize back in 2003. It was, well, why are there colors? To match your pajamas, you know? Why not? And then we have a lot of people that want the bright pink ones so that they can find them easier when if they fall off in the middle of the night. So
oh, that's clever. I didn't know why they were hot pink, but I really like the hot pink.
Yeah. Okay, so we're going to go to live Q&A, and we've got a lot of them. I'm going to direct this one to, I guess, Dr. Odell, who's the leading investigator with the clinical study regarding the first half of the discussion. how was the tear breakup time measured, fluorescein or with NIBUT, the NIBUT?
I think well, Crystal, if I'm not wrong, you actually were able to do NICBUT on your patients, but we all did also the fluorescein tear breakup time. At the time of the study, I didn't have access to non-invasive tear breakup time, so mine were with fluorescein, and I think that Crystal had both in her, what she gave us as far as data was both the non-invasive and the fluorescein tear breakup.
True.
Okay. Then another question, I'll just put this out to everybody, and maybe Dr. Brimer, you can handle this one. How often can you manually express meibomian glands per year?
Is there a limit? I mean, basically every patient that I see every day, I express glands. Now I'm not doing it therapeutically, I'm doing it diagnostically just to see what's our status. And they expect that. They expect me to debride the lid and to do a quick expression, because then that's telling us how are we doing on our anti-inflammatory, on our systemic control, on our supplements. Do we need to make any adjustments so that we can thin out this meibum? Any opinion on that, Laura, Leslie?
I think that, if I'm thinking about therapeutic, if that maybe is how that question is coming in, I don't know that there is a limit. I feel like I'm doing treatments and expression until I can yield clear meibum. So I feel like what you see coming out of the glands kind of becomes the way that you know when to maybe cease treatment, or that you've kind of achieved your success. I find that sometimes doctors will say something failed as far as any kind of expression, but I feel like they also don't have a good starting point that they then use as a reference point after, and they just go solely on what the patient's telling them. So I think the best thing that you can do is use what you're saying, Crystal, with what's coming out of the gland and visibly seeing the meibum, and use that and see the change go from thickened meibum, toothpaste quality back to olive oil. You now know you're making an improvement in the function.
Yeah, that's one of the best things I did was when I was customizing my EMR. I've got radio buttons now where I document the amount of oil coming out, but also the consistency. And so then I'm able to get excited with that patient and tell them, oh my gosh, we just upgraded you 2 clicks on each eye. And that means something to them. It kind of gives them permission to feel better.
Yeah.
Any thoughts, Dr.?
We have a little victory dance when we get olive oil back. Everybody's just like, woo! We try to capture it on video and show the patient, like, I have oil. It's like, yes, you have oil.
I love it. That's what we hear this a lot at IECO all the time about the patient, because the way that we package the product, the Tranquil Vibes, which is available. Some question was, is it available for purchase? Yes, it is, in office or at home. And then the XL also, the difference in the retail prices, sometimes, if you go the entry level, they're usually $20-25. If you're jumping to something that's now $80 retail, how do you overcome that circumstance? And I always say, I'd love your feedback, but I always say, well, really, if you cost it out per application, you're looking at difference of pennies per application. Like it's, 14 cents per use for your ones that get 180 uses out of them. And for like the advanced kit, Tranquilize XL advanced kit is 15 cents per use. So you really need to put it in the context of the number of applications. But I would love your feedback and just your experience. And I'd also say that really the rubber, it's where the rubber meets the road. If patients start feeling better faster, then the compliance goes way up. And to me, we've always said for 18 years, everything we can do for compliance is what we're up to. So I'd love your thoughts on that.
Start. I always talk about value, not cost, and they're going to get a quicker, bigger return. And when they are investing not just dollars, but minutes per day, all of a sudden it matters. I say, I don't want you going through the motions and thinking you're doing a good thing. And here we've wasted 2 months and you come back and we haven't gone anywhere because it wasn't enough. And that seems to resonate.
That's great advice. Dr. Odell, thoughts on that?
I actually sometimes do use, I like that idea of using value, not cost. I sometimes do break it down though into what you said earlier, 15 cents a day with the XL mask, just because, well, honestly, because sometimes they're leaving and they're not just purchasing a mask at the time of checkout, they're purchasing a cleanser or they're purchasing some kind of omega supplement as well. And I will say though that patients they want something that works. I think a lot of times when they're coming to one of us, they're willing to try something that we're recommending because they've been through other treatments that haven't yielded success. But I think it's, even in a doctor that's not a tertiary kind of referral setter for dry eye, these masks are not really a sell. You're really just providing a better service to the patient, right? So if you're doing a beaded mask for moderate to advanced MGD, you're not going to see the results like Crystal's saying. You're not going to see that in 2 and 3 months because you need that increased duration and a longer heat and that moist heat. So I think if you really want to be treating MGD, you need to think about it like stages, and you need to know that you need different tools for different stages.
Super. Any thoughts, Dr. Periman?
Oh, I love that discussion. I love that approach. And it's my general philosophy is to give them the tools they need to get the job done and help them celebrate all those little victories. And if you can create a temporal relationship between the intervention and feeling better, that's a driver for adherence to therapy and success with therapy. All of these approaches work. We're just trying to create that connection and understanding in our patients.
Oh, I love it. That's wonderful. That was like August last year, right? When Drs. Corbin now did their lecture on the paradigm shift. And it's really taking this approach of the patient has the ability to do things now at home that they couldn't even do 5 years ago. And same thing in practice in office. And when you marry those two and you're working in partnership, it's magic. And it's getting the right products for the right person, the right treatment in office. Another one, and this would be interesting. What percentage of your moderate to severe MGD patients that you see also have nocturnal evaporative stress? Dr. Periman?
Yeah, it's pretty high. I haven't tracked the actual number, but I'm more often surprised when I don't see lid seal insufficiency in the severe patient than when I do, if that makes sense. And to your last point about putting more tools in the patient's hands and creating understanding about it, I just want to say thank you for all the work that you do in creating these excellent tools that patients can use at home. But also there's a series of online videos that this team has put together that patients really appreciate being able to see. So there's resources out there. Patients can look for stuff. It can help save you chair time. Our dear colleagues lean on these resources. We've had patients come on and tell their story and the different things that they've used and what's worked for them. And we've gotten a lot of good feedback from the entire series. You can find it on YouTube, and there's also links on the IECO site.
Oh, thank you. Yeah, and I would love to hear what the Drs. Odell and Brimer about the nocturnal back that compare just the correlation. But on that note, I said thank you for bringing that up. We're really passionate about our patient educational series that we started 6 months ago, and incredibly fortunate to have these 4 doctors on the expert panel direct to patient. And the content is something that your patients will really appreciate, because now it's not just you saying it. They're hearing other doctors say it, other dry eye experts saying it, and it's really wonderful. So we're gonna get back into that again back in May. We started it back in October. So thanks for bringing that up. Drs. Brimer and Odell, any comments or thoughts about just the correlation? Like when you're seeing that moderate to severe, you're always looking for the NES, the nocturnal evaporative stress. And are you seeing the same thing that Dr. Periman is, the majority?
I am, and I am adamant about looking in every single patient. And then correlating it to one of my questions on my dry eye questionnaire is, how do you feel when you first wake up in the morning? And then in parentheses, it says, still lying in bed, and the alarm clock goes off. That's what I want to know. Or I'll say, if you get up in the middle of the night, how do your eyes feel? And then we talk through it reasonably and say, okay, you should wake up feeling your best. There is no dry eye in a closed eye environment. So let's walk through what are the possible reasons for you to wake up uncomfortable, and just kind of help them reach the same conclusion. And I definitely use the transilluminator, and not only with the core Blackie technique, but also as I'm coming at them with the transilluminator, I'm looking at the seal to see if I can see some little tear film glistening, and that helps me identify it much quicker. And then I go ahead with the core Blackie method and just compare my results between the two, but very, very high correlation.
Wonderful. Okay. Well, not wonderful, but it's wonderful that we have the tools to be able to look for that now, and then the solutions for them, because it's something. I think that it's a highly overlooked area of the evaporative stress at night. Another question, this one.
I agree, but if you look at the study that Dr. Periman was talking about, it's such an overlooked thing, but it's such a powerful one. 80% of patients that are resisting, responding to our topical therapies as we want them to, have an inadequate lid seal, and just identifying it and giving them the tools they need to help make that environment less of a dry eye environment overnight is really life-changing for patients.
Mm-hmm.
Yeah, that's great. Well said. There's another, this is for rosacea patients with MGD, do you modify your hot compress protocol? I don't know who wants to take that one on. Dr. Periman?
Sure, I'll take it.
Okay.
So it's not uncommon for patients with significant uncontrolled rosacea to report that the hot packs are not as soothing as they would expect, and other patients have reported. And really, if you bring the rosacea under control with your dietary approach, we recommend the Whole30. With your omega supplementation, we recommend Hydro Eye. With your immunomodulatory controls, and also with IPL treatments, then as that element comes under control, then they tolerate the hot therapy much, much better, and you're able to get that aspect controlled as well.
Wonderful. That's a great question. And then this one was, it's not related necessarily to what we discussed, but I may as well put it out there too, but because I think it's probably common. What do each of you like to easily debride the lid?
I use the Carpecchi debrider, and the laugh had nothing to do with that, except I had it in my little brooder pot. They have a little hot pot that the bees get 450 degrees, and I had it sanitizing in there, and I grabbed it and dropped it on my leg. It's been 3 weeks, and I have these 2 burn marks on my thigh in the shape of the Carpecchi debrider. So
it does get really hot, actually. I feel that. I also use Carpecchi, but I've also used Dr. Epstein has a debrider as well, so I kind of go back and forth between those two, and a foreign body spud as well.
Great.
I use Chalazion Curette and an Epstein debrider, and I would love to try the Carpecchi debrider too.
Yeah, there's a disposable one now called the eye stick, the lid stick. And that's nice, because in COVID world, it's so nice to be able to have a brand new something and throw it away.
Perfect.
I use
Actually,
the lid
that's a good point.
stick, but
And
I
the
didn't
zest
use
kit.
it for I don't use it to debride. Do you use the white hard plastic side?
Yeah, so
3
it's
o'clock.
shaped like a half moon, and it's
6
flat
o'clock.
part.
I think we're getting cut off.
Okay.
Thank you so much, everybody, for joining us, and thank you, wonderful panel, for all of your expertise. And I hope everybody enjoys the rest of the event. Take care.